in those 3 locations. Sorry, just got a recording news flash there. So I would just say that our every hospital that we have and every clinic has a little bit of different issues, dynamics. I'm currently at MCR, holed up in a little bitty area because there's not a lot of places to get quiet for a meeting. And this hospital is a level 1 trauma center with 3 ICUs at this point. Then we have Greeley, which is a very different population demographically, but a brand new booming hospital where we are sometimes embedded up to 25% of the patients at any given time. And then Fort Collins, Poudre Valley Hospital, a little bit of everything. And then our oncology clinics. I will say that we are working really hard. This program is 10 years old from when it first started at PVH, and it's grown by leaps and bounds. And our goal really is, especially for those patients who have cancer, are seen in our outpatient clinic, to provide good continuity. And not always possible. I had somebody this week who's been diagnosed with cancer for multiple years, seen by one of our oncologists. We were just consulted to support during this admission, and a caregiver said, well, why now? And I said, that's a great question, because we could have been consulted and part of your care team for a really long time. And here's maybe some of the reasons that now is the time. And so I'm trying to think. One of the challenges that we are currently facing this week is we have someone out in the Greeley Hospital who speaks a dialect from Africa, and we cannot find a translator or an interpreter. Not through Language Line, not through. We've kind of exhausted a lot of resources. They actually have called a consulate in DC to see if we can get somebody. Making sure that we're matching people's needs is one of the biggest things we face. So I don't know. I don't want to just monopolize the talk. So I can leave it there. And maybe, I don't know if Travis and Megan want to talk a little bit, and then we can answer questions, or you can ask me questions. However.
Travis, do you want to talk first for Grand Junction?
Sure, I'll talk. Yeah, Colleen, I was just recognizing that's a challenge a lot of times, making sure the communication lines can stay open. Yeah, my name's Travis Klein. I'm a nurse practitioner. I work in Grand Junction. Like Megan, we have had some shared experience at different times working for the 2 kind of main organizations that have palliative care as an option here in Grand Junction. One is the largest hospital in the area, St. Mary's Hospital. It's got 300 or so beds. It's like a level 2 trauma center. Pretty lot of admissions and discharges. I guess that's one way you measure size of hospital, is it's got a pretty big catchment area, which is one of the reasons I recognize my bias here, but feel like should have a really robust palliative care service. Let's see, the other organization is a community organization called Hope West Hospice, which is primarily by and large a hospice organization, but has had a little bit of palliative care type support for certain folks. And that continues to change a little bit, as does the inpatient service profile. I think for a variety of reasons, but it seems like there has been some contraction of the palliative care availability in our community, especially since the time of COVID. I don't know. I have to think that at least in part it's related to financial objectives, and maybe some of the decisions at the hospital level have been more focused on how to sort of make up that lost revenue. And as we all probably recognize palliative care as an inpatient service is not really one that makes a lot of money. So I think some of the decision making is probably around that, but also there has been transition, I guess I would say acquisition of the SCL hospitals into the Intermountain, larger Utah-based corporate hospital system. And a lot of times when there's those kinds of transitions, there's some, changes in personnel and administrative staff and leadership and things like that. And to whatever extent that has impacted what's been going on with palliative care, I feel like that's just an important thing to recognize. But certainly we have experienced first sort of a buildup of palliative care availability within the hospital setting, and then a pretty sharp decline where the total FTE was cut in half, even a little bit more than half. And then as sort of there's been a little bit of rebuilding, it still remains lower than it was at one point. That's all the while, while I guess the number of admissions and the hospital, like in general, continues to expand. So it sounds like it's pretty stable right now. They at least can cover the pillars of palliative care: social work, chaplaincy, advanced practice nursing. There's one full-time physician, so they do cover those bases. I'm not sure what the consult volume looks like right now. Megan can probably talk about that a little bit, but around the community, that's really kind of the only show in town. The other smaller hospitals have no palliative care. Neither of the two cancer institutes have any palliative care. So really the inpatient service at the hospital is the only solid palliative care service, with a little bit of activity going on through the hospice agency. So that's kind of where we sit right now as a community, and it feels like the community in general continues to grow. A lot of people moving here, lots of retirees and things, like a huge need. I mean, you feel it out in the community. So I feel like some of the barriers are really at the organizational level, and hopefully we'll see some changes with that. I should say the VA system is a big VA system here too. And just recently, like within the past few months, there's some signals that they are really committing to expanding some of their services, hiring more people, having a dedicated outpatient palliative care service, referring newly diagnosed cancer patients to their palliative care program, and then letting the palliative care program kind of determine if, how much it seems appropriate to get involved in things like that. And that's giant, especially because there isn't palliative care within the cancer institutes that are here. So yeah, I guess that's all I'll say right now. Megan, please add to that.
Yeah, I'll echo what Travis said, that my experience here, and I've been in Grand Junction for, I think it's coming up on 2 years or so. But my experience here has been that the need far exceeds the availability here in Grand Junction, not only just in the hospital environment, but in the community especially. I first moved up here and worked for Hope West in the community, on the community side, in the hopes of kind of growing their palliative care availability to the community. And that had its own challenges. I think that there is certainly all of the players in the community have voiced the need for community palliative care here. I hear that all the time, but it's who takes the reins on that and who grows that. And that, I do think, along with what Travis said, has been a financial challenge of who will kind of bear the burden of that, I guess. A huge difference that I saw coming from the Front Range to the Western Slope here is there are so many organizations on the Front Range that will offer home palliative care service and see all types of different patients through those services. And here in Grand Junction, the limitation of only having 2 hospice providers, that being Hope West and Abode, there hasn't been that level, I guess, of competition that sometimes drives that palliative care availability from what I've seen before. I do think it is encouraging to me that at least, you know, in the hospital that we do have these different service lines, you know, or the pillars of palliative care, in having social work chaplain, you know, APP and physician availability. But the acuity at our hospital, it being a regional center, can be extremely high. And even with the team that we have now, we do have a hard time meeting the need. We can run at a census of, you know, kind of around 30 on any given day, and generally 2 providers on the team on any given day, that are able to do kind of billable visits. And that's a limitation in and of itself, you know, to have 2 people, we cannot see 30 people in that role. So I have a lot of hopes that things will continue to grow in the future after this kind of contraction that's happened. But that is kind of a challenge that we're facing right now here in Grand Junction.
I'd love to kind of piggyback on a couple of things that Megan and Travis have said. And Megan, it's funny, I had made a note about community-based availability here on the Front Range, and that has changed since COVID. We still have more organizations. However, what we've noticed is that the community organizations aren't really wanting to prescribe medications. They want to act more as a consultative service and make recommendations to a primary care. And as you guys know, that's a really big deal if we're talking about good symptom management with things that PCPs may not be comfortable with. Sometimes that's why they refer. And we've also run into a situation with community-based organizations where our patients are telling us that they're getting kind of kicked off. Like you would think of somebody graduating from hospice, they're being told by their team that they no longer need palliative care. And I think that speaks to resources more than anything. I know that what we here in the hospital, what we're noticing is that again, I think this speaks to Travis's talking about the finances and the pinch that a lot of health systems are feeling. But hospital social work and discharge planning, our departments, we're seeing a reduction in the amount of people, and therefore their caseloads are getting higher, which means they have less bandwidth, which means we have less people to collaborate with. So it's just this trickle down effect. The other thing that we face always, even without these things, are that we see a high percentage of people from Wyoming, rural Nebraska, rural, sometimes Kansas, but not often. We do get, all over Wyoming. And sometimes really far out, and occasionally we get other states. But for our biggest, some of those bigger, the towns that we see the most often, sometimes there is no hospice agency to send somebody home to. So it just providing good care here, providing working on a good, safe, feasible plan to get someone out of the hospital is, it just seems like it's getting harder.
Thank you, Anne. I wanted to make sure you all had time to chime in. Forgive our loose structure today, but
yeah, no worries. Well, I think I'm going to let Sarah talk a little bit about, we have kind of a good happy ending story for our palliative care down here in Durango. So I'll let Sarah talk about that.
Hi, I'm Sarah Powers. I'm one of the nurse practitioners down here in Durango. We work for Mercy Palliative Care. We cover 2 counties down here. It's about 4,000 square miles. We have 5 nurse practitioners and 1 physician. And we are an extremely robust palliative care program, certainly the most robust in the state and potentially one of the most robust in the country. We have a home care program that we see patients in their home, skilled nursing facility, assisted living facility. We've got about average 310, 320 caseload that we manage there. And then most of those patients we see monthly, and we do have a also very robust inpatient program. Mercy Regional Medical Center is the only hospital. Well, I can't say the only one. It is the only one in Southwest Colorado that provides palliative care. There are a few other nearby hospitals, but certainly none of them provide palliative care. And we are the highest level care hospital in the region. New Mexico has a Farmington, which is a much larger town, but they don't have a palliative care program. And of course, they serve New Mexico. But we do serve patients all the way up to that New Mexico border. Like I said, we're a robust program. We take all patients that have any type of life-limiting illness in which they are suffering and they need extra attention and extra care. And so we are very fortunate that we have a very invested upper management with our facility here, Mercy Regional Medical Center, as well as formerly Centura, now Common Spirit, that is really very supportive of palliative care services and making sure that they're serving the community. And so we have had a good investment from them, as evidenced by how many individuals we have working for the company. But let's see, what do I need to include? I think part of our success is because we are connected. We're a sort of a triple branch. We've got home health, hospice, and palliative care are all services that we provide. And so we're really able to provide a continuum of care for patients, whether the referrals coming from the primary care patient's office or the hospital. We're really able to provide a continuum of care for individuals at the end of their life. And, it may start with a broken hip and home health goes in and they see there's a need there for better symptom control and other issues. And so we'll get a referral, and then eventually we hold their hand until we hand them off to a hospice. So we don't have a situation here where we have to discharge our patients because they don't qualify. I can't imagine that would ever be a possibility. I mean, once you qualify for palliative care, you're always going to qualify for palliative care in most situations, I think. I think what we're trying to do as a system, Centura, formerly Centura, now Common Spirit, is there are a few champions within the organization at a higher level that are really pushing for palliative care as one of their main initiatives, one of their main goals, and that would be a statewide program. Common Spirit also covers Kansas and Utah, and so I see expansion eventually going to those regions as well. Really, the goal is all about improved patient care. And in this system, this healthcare system that we're in now, there are so many holes and so many gaps and so many demands. It's very difficult for a primary care provider or an oncologist to be able to really help that individual with their last few chapters of their life, and we found a way down here to make that happen. And I think that we're going to see that expand quite a bit on the Front Range as well, as Common Spirit seeks to expand our services there.
Yeah, I can speak just a little bit about what we have going on up in Denver. I'm the taken over recently I'm the hospice director down here. And then I've taken over for St. Anthony's Hospice, which is a new hospice program up there. And then I also help with the home palliative care program in Denver. And we won't kick people off, and we will prescribe up there in Denver. So if you're running into that and you want somebody in the Front Range, please reach out to Common Spirit. We will take folks, and we're happy to grow. So yep, we got room there. And like Sarah said, we're also trying to duplicate that model up there. We're very closely tied with our home health agency up there, and our hospice and palliative care are very closely tied. So we're really trying to help with that whole continuum of care model. We have some palliative care in St. Anthony's and St. Anthony's North. and then down in Penrose and St. Francis, and we're trying to make it less siloed. So we're more of a continuum down here in Durango. We have our nurse practitioners and myself. I'm covering mostly inpatient palliative care, but the nurse practitioners will roll through and cover some inpatient palliative care, and then be in the different facilities and home, and we all work together. You can hear clicking away back in the background. We got kind of all here in our office, most of us here today, and so we really have a very just continuous model. Even with just palliative care, we have great communication with inpatient and outpatient, and so we really try to work together, and it just is a lot more smooth. And the folks, when I'm inpatient and I know one's going home and where they're going to be, if there's anything complicated, I can just pick up the phone and call Sarah or Sheena or Jen or Barb and kind of chat about it. And so it's a really it's a nice model, and we're really closely connected and help each other out.
It does take quite a bit of investment in the community as well, educating the doctors and, the home care and oncology and all kinds of practitioners of what our services are and what we're able to cover. And many of them are surprised at what we're able to do. Some of them want us to do a heck of a lot more, but it takes maintenance, and it takes a lot of communication with the various individuals, whether they're associated with Common Spirit or not, and just really describing what the program is and how people can benefit from it. We do have a very successful patient satisfaction rate. Most of these patients really feel like, we're family now. And so everyone, I can't say everyone, almost everyone is very pleased with the palliative care services that they receive here. And the question always comes up, why don't they have this in such and such a town? Or why isn't this here or there? And the answer is because this is really a cutting edge way of providing palliative care, so that it's sustainable by having the three branches, the hospice, palliative care, and home health. But it's, it's the right thing to do. And so, we're hoping that this model gets spread around the country, and that there's a growing investment in this type of service.
Awesome. Thanks for sharing. There's several good questions in the chat, and I think we can loop them together. So how do we grow Megan and Travis's clinical base and revenue stream, right? Like how can we fund some of these visits? How can we clone what's going on in Durango in terms of number of clinicians, and help Megan and Travis and Colleen to some degree? If you had a crystal ball, Megan, what would you do?
Well, I sure wish that I had a crystal ball. I think that what I would do is, in full disclosure, having worked for Centura, I spent a week down in Durango with their team when I was training in my new role. And having a model like theirs would be ideal, I think, in any regional community. And so I think, when I'm looking at the larger health systems here, being Community and Intermountain, the fact that we do not have in-house hospice services here, I think is what impedes that continuum of care. I think that our systems have done a really good job partnering with the community organization of Hope West that's been here for 30 years. And I could see the possibility of them collaborating to develop a better continuum of care that could benefit both sides. But I think, as Travis spoke to, changes on the organizational level at Hope West, there was a huge change in leadership with a new CEO that replaced the one that was the founding CEO, who had been there almost 30 years. All of those changes happening at the same time have been kind of an inhibitor to that. So I think continuing to call out the need for palliative care in our community is a big part, and essentially getting the commitment and the buy-in from either or both the large community organization and the more, hospital-oriented organization. I know that Intermountain traditionally in Utah has a pretty significant palliative care presence. They also have they do provide hospice services in a lot of their communities. So I think as that merger continues to come together, that we could see some mimicking of practices that they have done long-term in Utah.
Yeah.
So those are my hopes.
Yeah, I love the crystal ball question because it just here's my crystal ball. So I would like to see I think it's about, a lot of times it comes back to payment on how to do this stuff. And so I'm interested in a model like California has done with the expansion under Medicaid. And overnight, once you make palliative care reimbursable, you have agencies popping up in the community that are going to provide palliative care. And that works really well. And we in Grand Junction have a lot of Medicaid enrollees, and we have a really high number of dually enrolled folks. A lot of the Medicare side is people who are on Medicare because of disability, not because they're 65 or older. So a big dual enrollment population. So in lieu of something like Medicaid expansion to cover that, which I would like to see eventually, I hope. I mean, it just makes sense. I think it's a matter of time. But in the meantime, payers can step in and direct that a little bit more. I have seen that a lot as well. We have a large United Healthcare population here in Grand Junction too, largely because of the Rocky Mountain Healthcare sort of takeover by United back in 2015. And that's who has the largest number of enrollees into the dual care plans. And so these are just almost uniformly high needs folks, all palliative care type folks. And so they could, as they have in other markets, to use the business speak, kind of pushed out a palliative care program or call it serious illness program, call it high needs support, whatever you want to call it. But it's community-based, interdisciplinary, home visits included, follow up through virtual or telephonic support. So, palliative care is what I call that. But anyway, they could really do that. I mean, resources are not a limitation for an organization like that. So that could happen anytime. That is something I wish for as well. That would help overlay with the infrastructure and healthcare that already exists here. So we'll see.
Yeah, I would agree with that, Travis. And I think, the Hope West has certain agreements with Rocky Mountain Health Plans. So they are able to provide what they call palliative care services for those patients that is reimbursed. But it looks a lot different, than what we traditionally think of as a provider-led palliative care service or a really robust palliative care service. And so I do think that there is certainly room to grow with that. Absolutely.
Pauline, I'll ask you the crystal ball, question. What would help you as you're covering for people in 3 states, 4 states? Did we lose you, Colleen? You're on mute.
Sorry, could not get my touch screen to respond. I love the model that Anne described, the continuum of care. I think that is really, I worked for a system in Michigan that was the same thing. And I think I have the reverse career path of Krista. I was in hospice and now palliative care. And so to have a continuum of care that includes home care, hospice, and palliative care is huge. And I know that that's not the right move for every health system, but I think that makes a big difference. I think what we run into for some of our more rural folks is that they're going back to communities that have different healthcare systems. And so that handoff is clunky. You know, and then some of those smaller agencies in the smaller towns don't exist from one year to the next. So that's, yeah, I mean, I love that idea. I think that that just makes everything smoother for everybody else.
I will say though, not all of our patients come from home health. You know, a lot of them do just come from
Right.
members in the community, oncology and, primary care providers. And then we end up referring our palliative care patients to home health. So,
Mhm.
so it's not necessarily that it begins with the home health aspect of it, but that we do have that resource to utilize if we need to. I did want to touch base on our reimbursement situation. So Medicare Part B covers our services in the community to a certain percentage. It's usually 85%. And then if an individual has a secondary, then there's usually no out-of-pocket expense for palliative care services. As far as looking at it from the financial perspective, as you all know, each insurance company provides a different amount of money that they're going to pay for your services. So Medicare pays a fairly consistent amount. Medicaid, there is a question whether or not long-term Medicaid is actually covering that percentage that Medicare Part B is not covering in the long-term setting. That may actually be happening, but I know right now, Michelle Patrino, she's working on issues with getting Medicaid as far as, system-wide for people who are not on Medicare, having Colorado Medicaid help pay for palliative care services. So I certainly hope that that is something that legislators are encouraged by and willing to invest in. But we're able to stay afloat, although it may not be by much, as a palliative care outpatient program on the Medicare Part B reimbursement.
Well, plus because we partner with we're part of the same program as our home health and hospice, is that some of their finances help support us.
Yeah. The overhead, the office overhead, mileage reimbursement, supplies, those kinds of things. Yeah.
I think we found an important topic. And Michelle, if you wanted to briefly explain, how you can potentially help Travis, Colleen, Megan, what is the state trying to do?
So the state has received a technical assistance grant from national organization NASHB with a lot of expertise. They are in fact working with California, to your point, Travis, around some models of care, some actuarial support, just sharing some best practices across Medicaid agencies. So with that technical assistance and a group that had been formed and was already doing some work looking at some of the data, I've come in to help them more from a project management perspective. I'm not a clinician, but I've worked in healthcare my whole career. So I'm trying to get up to speed on it. But the goal is to design what an outpatient program might look like, what it might cover, what providers it might include, what kind of patients it might include, do some of that actuarial modeling, and then they will have to go through the formal process of doing the cost analysis and then putting it forward to say, with this kind of support, we could put in this kind of benefit, and they have to get permission to do that and get it built into the budget. So best case scenario, it's a couple years out before we could be covering anybody under a new palliative care benefit, but that is what we're working towards.
Well, I volunteer, Travis and Megan and Colleen. Our hats go off to Durango for making it happen. And to Nancy's point, and I'm not saying the others aren't. I'm just saying, like, all of us in healthcare have our own unique struggles. And, to Nancy's point, it's making sure people understand the difference between palliative care and hospice. And I think in 2023, we're still encountering that on every possible level, regardless of whether we're in rural settings or urban settings. And what a snowstorm does to people in Grand Junction, or what a snowstorm does to people on I-25, or, where can you send these patients? What about the length of stay? What are there skilled nursing facilities that have hospice beds for that portion of palliative care. Just so many big concepts, and I think all 6 of you are remarkable, incredible people trying to do the absolute best you can in some amazing situations that are unique to the place you call home and love so much. And whether it's the state or the coalition, whatever anybody can do to help anybody. And to Travis's point, you know, maybe he can connect with you offline about payer mix and you know, the team and just how to kind of connect and what we can do. Because I think as Krista Burke and Bonnie were planning this webinar series, or at least trying to get the discussions going, is figuring out what are the needs of people in Colorado. And it sounds like there's some unique needs, but there are also some larger needs where maybe within the state we can keep working together. So kind of round robin, if we can, if our speakers would like to do one last save rounds of what would you like from the state, what would you like from the coalition, how do you see the future, you know, just what would you like to share, what would you like people to know? So Megan, I'll put you on the spot first in Hollywood Squares.
I feel like I've been on the spot a lot today. Geez. I think advocacy, you know, I think just having a voice, sharing success stories that you've witnessed in other communities that could parlay into the Grand Junction area with regard to palliative care. You know, we palliative care providers are all very passionate, and sometimes it's hard when you continue to vocalize your thoughts, but you feel like you're a squeaky wheel because you're employed by the organization. So I think outside voices can always be very helpful in talking to leadership in a community.
Thank you. Travis, what may we do? What would you like as a holiday present?
Well, you know, something that seems pretty tangible, just given the history of palliative care and the foothold within the oncology community, that seems to be a pretty kind of I don't know, low-hanging fruit in this community, that the cancer agencies don't have any dedicated palliative care. And when people within broader organizations, support groups, you know, state level agencies, the coalition, and, you know, and patients and caregivers are talking about palliative care and asking about palliative care, continuing to kind of get that message out there so that, you know, people are informed and more aware. And then organizations and agencies like the local cancer institutes, you know, have a harder time not figuring out how to build that in. So you know, just including palliative care and continuing to spread the word that way.
We'll keep brainstorming with you and with Bing, with the state and grants, and with Michelle.
Harlan, can I just share something real quick?
Yeah.
I was at a meeting the other day with a group of nonprofits for kids' cancers, and I put in the chat, I really think having patients help you push this. I mean, it was a sad story. This one family shared that they had a child that had cancer for 8 years. They were at Children's, which I think does a pretty good job letting services be known. And after 8 years, unfortunately, they lost their child. The mom's on a mission now to share services, because I think the one aspect that's being missed here is if patients don't know it exists, they don't know to ask for it. So there's your voice, in my opinion, and in what I do, because I started Epic 11 years ago, and all I ever hear is, I wish I would have known. I wish I would have known. So you know, if we can help, you know, that conversation along as a nonprofit, and I know many others would, but it's easy. And I've worked for a hospital. I know when there's things that are set up, but if patients don't know about it, you know, there's your need and there's your demand.
I would say we had a really good experience with Denver Children's because we had a kiddo come onto our hospice down here in Durango, and we, you know, like I'm it for hospice and I'm not a pediatrician. And so that's always a little concerning, but the Denver Children's Palliative Care team reached out to me, made themselves accessible 24/7. They gave me all these contact numbers for help, you know, and how they can provide assistance. And they're trying to do that around the state because they know there's really not pediatric hospice anywhere but where they are. And so they're very open to helping with that in any way that they can. And they'll help with pediatric pal care too. So even for our providers that don't have pediatric background, they'll jump in and help in any way. So I think that's pretty awesome that they want to help in that way.
And Nancy, similar to I had a family personal experience, someone who lives up in Clear Creek or Gilpin County, so who has an oncologist, but palliative care came in towards the beginning of it was a stage 4 metastatic disease diagnosis, came in at the beginning, introduced themselves, checked and helped them at home because they had home hospice palliative services available. But my family member ended up having me tell them, it's time to tell your doctor you need palliative to revisit, because they were starting to not want to come down to appointments because they couldn't get the energy to get down to get to an appointment for fluids or for things, and they're sitting up there in the mountains. And it was just sad to me that the patient had to be the one to say, hey, could palliative care help me feel better at home right now? So I feel like Nancy's point is well taken. I think patient education on asking, and then oncologists' education on reintroducing it throughout the care continuum, because again, palliative isn't just as a transition to hospice. Palliative is symptom management. So I feel like we're missing that boat of the oncologists themselves understanding to keep reintroducing and offering it to a patient, because they may not really know the patient's ready for it or needs it, even though they should. It just depends on what the patient's telling them.
The other thing we hear all the time is they get bombarded in the beginning when they're first diagnosed and everything's given to them. They don't remember if they've just been given medication. Even if they have a caregiver, everybody's overwhelmed. So yeah, I mean, it can't just be at the beginning. If there's just, you know, websites or something, just like remember to go to your website. Because I know staff is, you know, everybody has a lot on their plate, but if the services are there and nobody knows about it, it's kind of pointless.
You know, it's my understanding that oncology, Medicare is requiring oncology to provide some type of palliative care information. That this is something that they are required as an oncology office to do. And so maybe part of our outreach is you know, to those particular cancer centers, or, you know, how do you promote your palliative care, and what, you know, to what extent are you promoting it? Is it just clicking, you know, on a couple things on the website, or do you have a live person for someone to speak to?
And I think navigation and when that is being introduced are key for those patients.
Well, it's straight up 1 o'clock. And I think Colleen had to hop off, but I'm going to stop the recording.